Hello all, welcome back to my show Chronicles of a Learner RN, and thank you for listening. My name's Ritika, I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today we'll be talking about the big dog of infections, sepsis. What it is, how it works, and what we do about it. And I have got so much to talk about in this episode that it's going to be split in two. As a disclaimer, I'll not be providing any personalised information. All names, numbers, and results will be altered to protect the privacy of the patient these stories are derived from. Also, apologies for my congested voice. I'm a little sick at the moment. Anyway, to start us off, I'm going to define sepsis out of a textbook without context. Then I'll build the context and understanding around this topic. And then we'll revisit this sentence and you'll understand the implications, the pathophysiology, and, well, how this applies to you. So here we go. The definition of sepsis, as I've learned it, is a life-threatening organ dysfunction due to dysregulated host response to infection. Now it is time to ask the question, what on earth does that mean? And the answer is, we'll get to that. But first we've got to discuss the basics. Got to ease you guys in so you don't get scared and run away. So Ritika, you ask, what do we start with? And the answer is infection for dummies. First we'll discuss what it is an infection, how it works, and then work out together how this minuscule infection can turn into something big and scary like sepsis. Now I lied a little. I said we'll start with infection for dummies, but in order to fully understand how an infection takes hold in our bodies, we'll have to discuss immunity and inflammation. Inflammation is the body's way of identifying, containing, and removing unwanted stuff. Now, stuff like bugs, viruses, cuts, bruises, breaks, you get the point. Anything that is abnormal in or on the body, inflammation or the inflammation cascade is what handles it. Now, as this is the infection for dummies, I'm not going to use fancy pants lingo that uni expects me to use, which is a huge relief. So say we've given ourselves a paper cut, and this scenario could easily be substituted for other things like inhaling airborne COVID viruses, or sharing a cup of food, or a plate of food with someone with a cold, which will transfer droplet viruses or bacteria. It's all interchangeable. So what happens first is that the body's quote-unquote alarm goes off. It goes, guys, something is happening. First responder immune cells called mast cells and macrophages get called. Whatever is affected, in this case our skin, releases enzymes that cause the surrounding blood vessels to widen and allow more cells to come for the rescue. These same enzymes, and there's a lot of them with a lot of different purposes, so we won't get into the nitty-gritty, also call in the big dogs, the white cells. This is why they need to widen the vessels, because white blood cells are bigger in size than your average Joe red blood cells. With the white blood cells come platelets, and in this case they begin to help clot formation and stop the bleeding. All these nifty little enzymes in white blood cells eat up the bad bacteria that was sitting on the paper before they take up the bloodstream. And Bob's your uncle, our finger is now red from the blood vessels widening, or vasodilation, swollen from the extra blood being present, and sore from hitting the nerves, and has stopped bleeding relatively quickly thanks to our trusty platelets. And that wraps up inflammation on the most basic of basic levels. If you're looking for more in depth, let me know in the comments below or shoot me an email. Inflammation is great and all, but it's a taxing process for the body to do every time something foreign is trying to make its way in. This is when immunity comes into play. We've got two inherent types of immunity, innate immunity and adaptive immunity. Innate immunity is basically first-line defense we just spoke about. It's not given to us, it's present from birth and includes all manner of protection like mucus, skin, stomach acid, and a certain set of cells I may or may not have mentioned previously. Another good point to make is that innate immunity does not remember. It attacks all the things it doesn't know the same, even if it has attacked the same thing before. Now, adaptive immunity is developed over time as we expose ourselves to more and more pathogens. The generalized category of white blood cells doesn't apply to this immune response. Specialized white blood cells called T cells and B cells target specific antigens they are familiar with. The immune system remembers what these antigens are from the first encounter and creates specialized antibodies to fight these antigens if they ever step foot near us again. So when we get a cold, our innate immune system begins to work overtime. It creates a bucket load of mucus, aka snot, to try and flush out the pathogen from the nose, which is likely how you got it in the first place. And is also why I sound so nasally and congested today, because my immune system is working overtime. It also increases body heat, causing a fever to try and burn these suckers alive. We've been led to believe for a very long time that fevers are bad and we need to get rid of them as soon as possible. But in recent years, studies are aiming to prove that this isn't necessarily true. Fevers in most people, excluding infants and immunocompromised people like chemotherapy patients or long-term corticosteroid users, are actually a good sign. It is showing that the body is fighting the infection. The new norm in terms of fever treatment is to let it do its thing until the symptoms show, like a headache or increased lethargy or just generally feeling like crap, which can happen when you have a fever or even when you don't have a fever. But for the most part, avoiding Panadol when you've got an average fever, and in my opinion, average fever is anything below 39 degrees, can actually help the body fight the infection faster. And the adaptive immunity is primarily garnered by vaccines. I can't speak today. A non-active version or potentially small dose of a live virus is injected into the body via intramuscular injection, which lets T cells and B cells come and go, get it out of my swamp. Oh, that was awful. Just forget I did that. And then remembers that exact line from Shrek to use again and again if we were ever exposed. In a practical sense, that's why most people that say get the chickenpox vaccine do not get a severe version of the virus, and why polio has been mostly eradicated. I say mostly because it's making a hot girl comeback in the face of growing numbers of unvaccinated children. So if inflammation and immunity are so cool, why would it be bad on a systemic or say full body scale? Well, the simple answer is the body does not have enough resources to handle said body needing all the inflammatory medias and white blood cells everywhere all the time and all at once. Our precious little bodies can only do so much. So when the body is telling the immune system it's needed pretty much everywhere, you can see how things would go south and fast. I'm going to throw out an Easter egg term, and I want you to keep in mind. Compensatory mechanisms. The body, fickle thing, loves to maintain a state called homeostasis. If something is out of whack, say your blood pressure, well, it'll find a way to compensate. In this case, the main thing the body does to compensate for a low BP is increase heart rate. Now, while I talk about my next few points, I want you to have a think about why increasing heart rate will offset a low BP. Let me know what you come up with in the comments below. And no cheating. We know how the body reacts and defends against pathogens. We know that, on the whole, the body is pretty good at fighting its own battles. But we also know that it is only really good for localized trauma. When we get to the whole body saying, help us, the immune system and inflammatory mediators, begin to decline in success. This is where sepsis joins the party. Sepsis is the result of systemic inflammation maxing out the immune system, and as a result, the infection takes control. I've written here, cue evil laugh, but I can't do an evil laugh, so we'll continue. So we go back to the definition, knowing what we do now about how the body fights infections. Sepsis is a life-threatening organ dysfunction due to a dysregulated host response to infection. This systemic inflammation and our immune system getting pooped is the dysregulated host response to infection. If this doesn't get sorted out, it's going to lead to life-threatening organ dysfunction. Now, how do we know what sepsis looks like? Well, our handy-dandy compensatory mechanisms can answer that for us. But I'm not revealing the answer just yet. We'll look into the pathophys of compensatory mechanisms soon. Just a quick side note before we get into the case studies I've prepared, I just want to state that the sepsis criteria I use as per my own hospital's policy is mildly outdated. I say mildly because it's still quite relevant, but there's new studies coming out. You may see these criteria referred to as SIRS, S-I-R-S. It stands for Systemic Inflammatory Response Syndrome, which is what we use to categorize these symptoms as. And then it was only called sepsis when infection was confirmed either by urine dip, blood tests, or diagnostic imaging. Anyway, continue on. To know what sepsis looks like, let's compare and contrast between two cases of pneumonia, a bacterial chest infection. Person A comes in acutely short of breath. They're breathing at a rate of 20 breaths per minute, and their heart rate is sitting at 80. But they've got a fever of 39 degrees. They've also got a crackly chest, partially confirming the suspicion for pneumonia. Now, person B comes in, who are also acutely short of breath, except they're breathing 24 times a minute. Their heart rate is sitting at 105, but their fever is 38.2. Which one is septic? Septic. You'd be inclined to think it's the person with the higher fever, right? Because that's what we've been taught. Higher fever equals worse infection. But that's not true. Sepsis criteria is based on respiratory rate, heart rate, fever, and once it's available, white blood cell count. Person A met one criteria, which was fever. Person B met 3 out of 4, pending blood test results. These criteria are a respiratory rate higher than 20, not higher than or equal to, higher than 20, a heart rate higher than 90, a temperature less than 36 or more than 38, and a white blood cell count of less than 4 or greater than 12 times 10 to the power of something I can't remember off the top of my head. To meet sepsis criteria, you need to hit 2 or more of these ranges. Therefore, person B is the person that's septic and should receive a Cat 2 at triage. Now, the criteria they met, if you had forgotten, they had a respiratory rate of 24, which is above 20, and they had a heart rate of 105, which is above 90. But they also had a fever of 38.2, which is above, 38. The way this has been standardized, so we all know what we're looking for, is called the sepsis pathway. It gives us risk factors, clues to look out for potential infections, and those criteria I just spoke about. And then what to do next. I advise that you guys go look up sepsis pathway. Have a look at the Safer Care Victoria outline. It'll give you all you need to know. And it'll show you the outline of the sepsis criteria, how we look at it in hospital. And then I'll discuss ongoing treatment very soon. Next episode, we'll discuss septic shock as well, and the further 3 criteria that if you go look it up, you might see of the sepsis pathway, that if met lead to increasing concerns of that life-threatening organ dysfunction thing I may have mentioned once or twice. So then, why do we have these criteria? How did we come to such arbitrary numbers to tell you who is sicker than who? Are they even arbitrary at all? Well, the answer is no, they are not arbitrary numbers. Now we're going to have that long-awaited conversation about compensatory mechanisms. We get told in nursing school that out of all the vital signs, respiratory rate is the first one to become abnormal and tell us something is off. For reference, a normal respiratory rate is from 12 to 20. Therefore, anything above 20 is ringing alarm bells saying, what's going on? What's going on, guys? The compensatory aspect of respiratory rate is complex and is related to the kidneys of all things. And I'll delve into that when I discuss VBGs next episode. So here we are, the heart, the good old heart. We know that a normal heart rate is between 60 to 100, but to meet sepsis criteria, you can have a normal heart rate, but it is still considered to be elevated. Why? Because even though the end range is 100, at rest when your heart rate is hitting between 90 and 100, well, that's not really normal. Now is the time to answer that question from before. Why does increasing heart rate offset a low BP? And by extension, why is a high heart rate bad if it is offsetting the low BP? To answer that, we have to revisit the concept of systemic inflammation. Like I said earlier, inflammation leads to vasodilation, blood vessel widening. If this is done on a systemic scale, this will reduce blood pressure. You may not feel it straight away, and this is because of these compensatory mechanisms. The heart senses that the blood pressure is reduced, so it picks up the pace. It's actually quite nifty. There are these things called baroreceptors. You can call them stretch receptors, which respond to the lack of stretch caused by the vasodilation all over the body, reducing how much blood returns to the heart. Now, how much blood pumps per minute is called cardiac output. Simple enough. The formula for cardiac output is stroke volume times heart rate in beats per minute. Now, what on earth is stroke volume? And I thought this was going to be a For Dummies lesson. I just can't help it. I get too carried away sometimes. But stroke volume in essence is how much blood the left ventricle ejects out of the heart to the whole body. So say if person B's stroke volume is usually 100 mils and their heart rate is usually 80 beats per minute, their cardiac output, while healthy, is 100 milliliters times 80 beats, which is 8 liters a minute. That is a lot. That is a lot of blood. Now we factor in that their whole body is like, damn, this infection has vasodilated and reduced venous return. We can say our stroke volume has halved, an arbitrary half. If our heart rate were to stay the same at 80 beats per minute, our new cardiac output would be 50 mils times 80 beats, which is only 4 liters. Our cardiac output has now halved. No surprises there though. The body can't have this, so it increases heart rate because that's the only thing it can do. It's going, oh, if we don't do something, we're going to be dead. So the only thing it physically can do is increase heart rate. So to get us back to a cardiac output of 8 liters, we must have a heart rate of 160, which is insane to think about. But the body doesn't do this in seconds. It takes time. Therefore, once we see a heart rate trending upwards, we begin to get worried because this is a telltale sign that the heart is beginning to compensate for something. So to sum it all up in a short sentence, the heart rate must increase to compensate for a low blood pressure, otherwise our cardiac output will drop, reducing perfusion to vital organs. The body is so cool like that, fixing its own problems. But the caveat is it can only do so for so long. Hence the life-threatening part of the sepsis definition. Once the body cannot compensate anymore, that is when we head into shock territory. We've learnt so much today, haven't we, guys? If you've stuck it out this far, thanks. You're a legend and a smart one too. Before I let you go about your day so you can go tell everyone what you've learnt, I want to briefly discuss treatment, because there's no point identifying sepsis if we don't know what to do about it. As per the sepsis pathway, there are 6 interventions that need to happen within 60 minutes of discovering that the person is meeting sepsis criteria. In a nutshell, it's 1. Administer oxygen. 2. Acquire 2 sets of blood cultures. 3. Collect a venous blood gas, or a VBG. 4. Fluid resuscitation. 5. Administer antibiotics. And 6. Frequent monitoring. So let's break it down. Administer oxygen. It is thought that without perfusion to the tissues are not receiving enough oxygen, and to give extra oxygen as a result. but it has been shown that unless the person is hypoxic, providing extra oxygen is no way beneficial. 2 sets of cultures. The reason they ask for 2 is to eliminate the possibility of a contaminated sample. If bacteria grows in one but not the other one, it may have come from somewhere else. 3. VBG. It provides a crucial picture of the state of the body through carbon dioxide, bicarb, and lactate monitoring. We'll discuss all of this in detail and its significance in the next episode. Fluid resuscitation. When stroke volume is low, cardiac output is low. To restore part of that stroke volume, we increase circulating volume by giving around 200 to 500 mils of IV fluid. However, this step is usually reserved for people that are exhibiting signs of shock. But in practice, we give fluids to most septic people because when we are sick, we are generally dehydrated too. We just don't provide fluid resuscitation. 5 is to administer antibiotics. Broad-spectrum antibiotics are given within 60 minutes for most and within 30 minutes for immunocompromised people. This is to cover them until we figure out what the infection source is. Narrow it down to a broad-ish spectrum antibiotic for that type of infection, so say a chest infection or a UTI. And then once the culture results come back, we can narrow it down even further to what the bacteria is sensitive to and what will yield the best results. And 6 is to continue to monitor. Sepsis can deteriorate fast if not kept on top of. This includes monitoring. It should be done at a higher frequency until they begin to show signs of improvement. So, wow, we've talked about a lot today. I hope I haven't made you bored out of your minds, but if you've made it this far, I can assume you've enjoyed it. I've written here things to take away or learning points. And to be honest, this whole episode is one big learning point. So I implore you to go do your own research. And in the face of potential sepsis in the community, use your own judgment and critical thinking to assess whether a visit to the GP would suffice or whether the 6 and 60 provided by the ED is the best course for you or your loved one. So, to recap today, we spoke about sepsis and infection for dummies. We went through the inflammation cascade and how this relates to the 2 main types of immunity, innate and adaptive, and what these look like. We've discussed that systemic inflammation is no good and how this leads to sepsis. I've mentioned the sepsis definition a few too many times. We've discussed the practical difference between a normal infection and a potentially septic infection, utilizing the sepsis pathway. We discussed compensatory mechanisms of the heart and how this plays into the sepsis pathway criteria and why we become concerned. Also, if you got the question correct, hats off to you, but also hats off to anyone that gave it a go. And finally, we spoke about treatment. 6 and 60, what we do, why we do it, and why we do it fast to begin sepsis treatment. If you're ready and eager for more, in my next episode, I'll be diving into the more advanced concepts relating to sepsis, including septic shock, VBGs for dummies, third spacing and fluid shifts, and why fluid resuscitation may not work, inotropes, vasopressors, and all things art lines. And lastly, before I sign off, I just wanted to reference Life in the Fast Lane and Safer Care Victoria for sources regarding sepsis definition and sepsis pathway. So, this wraps up this episode of my show, Chronicles of a Learner RN. I've certainly learnt a lot today, and I hope you have too. I've got a plethora of cases and learning experiences that I'm excited to share with you, those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Anyway, thank you for listening, and I hope you have a good day.